You're a physician. You've spent years mastering medicine, but deep down, you know your impact could be bigger. What if you could take your clinical expertise and use it to shape the future of healthcare without leaving medicine behind? I'm Dr. Allison Kerfman, and I went from being a practicing physician to a startup leader, launching a multi-nine-figure company that's transforming care for 35,000 children. And now I'm ready to show you how. Join the Startup Physicians Launchpad, a 6-week course designed to give you the tools, strategy, and connections to break into healthcare innovation. Whether you want to consult or advise or even launch your own venture, this is your roadmap. Spots are limited, so visit startupphysicians.com and register now. Your expertise is too valuable to stay on the sidelines. Let's change the future of healthcare together.
Startups may be one way that you're able to have the impact that you want and to solve a problem that you really care about. It's a very powerful way if it's done right, but it's not the only way to make an impact from one to many. And I really encourage people to think about what is the problem that they feel fundamentally very passionate about that they want to solve, and then find others that are like-minded and thinking in the same way that are doing something about it. And then just have conversations with them and learn about what they're doing, express interest in contributing to that cause and tell them why it matters to you, what you see day to day in the clinic and how it affects your ability to provide good patient care, and really be crisp on what it is that interests you and what you want to spend all day working on and all night thinking about.
Welcome to Startup Physicians. Please like and follow our show to join our community of physicians who are reimagining healthcare delivery. Hi, everyone, and welcome back to Startup Physicians. I'm your host, Dr. Allison Kerfman, and I am excited to have my friend and colleague, Dr. David Johnson, on the show today. Hi, David. Thanks for coming on.
Of course. Hi, Allison. Good to see you.
Great. Well, David and I first crossed paths when we were both at a firm in Nashville called Rubicon Founders. I was incubating the concept for Imagine, and we hit it off because he is someone who's fascinating, has a very interesting background and career as a physician, and has gone through a number of different avenues to solve problems that he felt were important to solve. So, David, I would love if you could start by just walking us through your journey, how you ended up on such a different place than most physicians do, and kind of your thoughts about, some of those opportunities you had along the way.
Yeah, absolutely. I sometimes wonder how I ended up in this type of position as well. So I essentially started my journey in a very typical fashion, going to med school at UNC Chapel Hill. And I was really interested in cancer and doing surgery, and really had no, definite path for my clinical future. And ended up finding urology and specifically urologic oncology as something that I found very interesting. It kind of checked all the boxes from what I wanted to do clinically and the types of patients I wanted to take care of. And then, when I learned about urologic oncology, two of the diseases that we treat most frequently, prostate cancer and kidney cancer, we have survival rates after surgery of like 98%. And I was like, well, that's exactly what I want to do. I just want to cure everyone that I operate on. And it sounded too good to be true. And in fact, it ended up being too good to be true. And I later found out that a lot of the cancers that were being operated on with prostate and early, small, localized kidney cancers actually weren't harmful to patients at all, but our surgeries were. And so I found this out as, a third year in med school. And I thought that was really interesting, both from an intellectual standpoint, that we could be hurting people that have cancer by doing surgery on them. But it was also, a really interesting public health question. And so I took a step back and did my master's in public health at UNC as well between my third and fourth year, and was really focused on how you separate what's good for a population versus sort of that one-on-one patient interaction. And so really focused on the concept of helping patients make really good decisions that are personalized, and assessing their values when making a decision around a preference-sensitive condition like localized prostate cancer. And my focus is really on appropriateness of care and quality improvement and sort of matching the right treatment for the right patient at the right time. So I went into my residency and really focused on health services research and outcomes research, but with sort of a slant on appropriateness. So, did some work on the percentage of kidney surgeries that we do on patients for suspected cancer that turned out to be benign tumors. And so basically these are by definition low value services. So we added no benefit to patients. Potentially maybe we're, relieving some anxiety. You could argue that, but we're causing them harm and cost. And so it's a low value service. It turns out a fairly high percentage of kidney tumors are removed that are benign. So this whole idea of appropriateness of care, cost, quality, shared decision making was like the through line of my residency. And so when I went to fellowship at UCLA to do more health services research and do my urologic oncology specialization, I kind of circled back to what I'd actually learned during my public health time, which was actually 2010. When the ACA was coming out. So all of this new promise of, this value-based care movement's going to start changing the way we practice, changing the financial incentives. And so here I was like 7-8 years later, and there was really nothing in the way of value-based care for specialists, other than maybe the bundle payments for joint replacement. And so I think the thing that really interested me the most around that time and what guided what I did for my research projects and then what's led me to my first job out of fellowship was the concept that the thing that needs to happen first, the thing that needs to change first is financial incentives need to be changed for specialists so that we're rewarded for delivering high quality care at a lower cost, not necessarily for doing more
and more surgeries.
Yeah. And I think prostate cancer is the prime example for that, which just also happened to be my clinical interest. And so I just found that sort of the right mix of value-based care, my clinical interests, and merging those together was what I wanted to focus my time on in fellowship. And so did a research project that was looking at sort of the financial outcomes at UCLA for prostate surgeries and modeling what would happen if we went from fee-for-service to sort of a bundle payment construct, and making the case that if we improve quality under a value-based payment construct, we can actually improve costs and revenue for the health system. So there's a win-win-win. Patients do better, and then financially, the health system is better off as well, which was in direct contrast to other research studies that I had read that were modeling out actually hospitals do better if patients are sicker and have a worse outcome and come back to the hospital more frequently after surgeries. There's a really interesting JAMA surgery paper about this, which showed the longer they stayed in the hospital, the more they were readmitted, the better the hospital does financially in fee for service, the worse.
Yeah, and that's just like such a direct misalignment. And so I was looking to prove the opposite with what I was doing. So I quickly realized that no one really cared about, a small prostate cancer pilot demonstration project. And so ended up meeting Patrick Conway, who is the former director of CMMI, who was also an alumni of the same fellowship that I did, at one of our conferences. And we just started talking about, what I was interested in conceptually. And, I was thinking about doing a research hybrid job out of fellowship. And at that time, he had left CMMI, where he had done all sort of the foundational work on value-based payment models for traditional Medicare. His major focus was really on value-based care centered around primary care providers or health systems. And he was then at that time the CEO of Blue Cross North Carolina and was essentially building a mini CMMI within the health plan, which happened to be the state where I grew up in. And for people that don't know this, CMMI is the Center for Medicaid and Medicare Innovation, which is an organization within the federal government that focuses a lot on how do we rebuild payment models and population health models to serve populations better.
Yeah, thank you. Yeah, and they're really the test bed for these alternative payment models where they realign incentives and then see what happens in terms of cost and quality and determines whether that's going to be something that is codified into statutory regulation in the future or not.
And Patrick Conway is a pediatrician.
He
So
is.
we both have that connection with him. And it's interesting how an introduction it sounds like at a conference led to a completely different path for you.
Exactly. And that's precisely what happened. I was talking to him about why I thought value-based care was interesting, why I was frustrated as a specialist who wanted to deliver high value care, that, it was harder to do that than it was to just operate on everybody. That's how we make money. That's what we're trained to do. And
it's how the system is
how the
incentivized.
system is set up. Exactly. And so his response was, hey, I'm doing, this thing in North Carolina. We're really, trying to innovate. We have a plan for what we're going to do with primary care, our statewide ACO network. But we really don't have a blueprint for how we're going to engage specialists in value-based care. And so he said, why don't you look into coming on as a medical director for specialty value-based care transformation? And I met the CMO at the time, Rahul Rajkumar, who was with him at CMMI, another very innovative physician and, a thought leader in value-based care in general, and just a really wonderful person. Met my future boss, Troy Smith, and a couple other people that Patrick had brought from CMMI who were just, brilliant, innovative thinkers on alternative payment models and redefining the financial incentives. And, I was hesitant at first, to be honest. My dad was a private practice physician in North Carolina, and the payer was always the enemy growing up.
Yeah.
It was always antagonistic. It was part of the reason he retired early. Just the, fighting with insurance companies all the time just gets exhausting. And so my first job out of fellowship, took a little bit of convincing my dad that I...
You probably were not ever anticipating that you were going to go work for a payer.
Never, not at all. And my fellowship mentor, Dr. Mark Litwin, is, one of the fathers of health services research. And I think I broke his heart as well, going into the payer side. But, what I saw was the opportunity to follow what had been interesting to me about, this whole question of why is it so hard to improve quality? Why is it so hard to do the right thing for patients in our current system? And if my thesis was the first thing that needs to change is the financial incentives, and the only way we can do that is by changing the way we're reimbursed and the types of payment models that we function under, a payer was the best place to do that. And I kind of happened into this really interesting situation in North Carolina. That was my first job out of fellowship. I ended up at a payer designing new payment models.
Did you have a financial background
No,
or an MBA?
I was an econ major in college because I always kind of found this stuff interesting, but I knew nothing about health insurance. I didn't even know what Medicare Advantage was when I started, which is really, really embarrassing.
That's kind of funny.
But learning on the job.
But you knew clinical work. You knew
Right.
what people deal with and how physicians make decisions and how the healthcare system works, right?
Exactly.
So you're applying your knowledge in a new way to a problem that really mattered to you.
Right. And what I did do during my fellowship is really dig into sort of the fundamentals of a payment model and sort of a risk contract, just from, desktop reading and understanding what was out there in terms of, population health payment models, episodic bundle payment models, the demonstrations that CMMI had done and other payers had done, and just trying to wrap my arms around what an alternative payment model is, and how that, can potentially be operationalized in today's world and into clinical practice. So yeah, that was my first stop at Blue Cross in North Carolina.
Very cool. What was next for you? Were you still practicing? I mean, some people try and balance the two.
When I was negotiating my role at Blue Cross North Carolina, I did my residency at UNC Chapel Hill, and my chairman at the time was very supportive of all of this type of work. And so I got a 1 day a week clinical position at UNC, where I get to operate. I get to see patients in clinic. I get to do the multidisciplinary cancer clinic 1 day a month. And then I do robotic surgeries with a fourth year resident a couple times a month. And so it's really a perfect blend of being part of the academic department, but sort of bringing something a little bit different than the typical role. And the interesting thing is that one of my colleagues at UNC did the exact same fellowship that I did. I literally took over his patients when he left UCLA to go back to UNC, and I came to UCLA as a fellow. He handed off patients to me on July 1st. He's doing a pure academic research hybrid job at UNC. And so, same training, but really this very different path based on sort of a single decision, a single sort of chance encounter.
Yeah. I mean, it's like all about people, and whether you are open to conversations
Right.
and talking about ideas, and when you're inspired by things, other people are inspired by things, and you make connections. And I think, I've talked to some other physicians who one of their core messages is you carve your own path.
Mm-hmm.
You may think like, oh, my only options are clinical 100% or clinical 80% and research 20%, or, it's just the thought of operating one day a week and then working at a health plan the rest of the time probably
Right.
does not cross anyone's minds, because I think you're the only person I know who's ever done that.
No, I agree. I mean, I think that's the hardest part, honestly, is solving for the clinical piece and finding a place that kind of fulfills the need to do what we trained so long to do. I mean, I was 36 when I finished my training. I didn't want to stop operating or stop taking care of patients because I love doing it. But I also felt like there was this opportunity to do something, different and outside of the clinical realm that I wanted to have it all. But honestly, I wouldn't have done the Blue Cross North Carolina job if I hadn't had the UNC urology job as well. So.
Absolutely. I mean, I get asked that a lot too, because I still practice pediatric emergency medicine. And like you, I trained for 10 years, 4 years of med school, 3 years of residency, 3 years of fellowship. Yours might have been a little longer. But 10 years to develop a skill set, and
Right.
especially a specialty that's highly procedural. I get asked a lot, like, how much do you need to work clinically to stay relevant clinically and stay up on your knowledge? And I mean, I put a lot of effort into that, and I know you do too. And even though you and I both have very different paths from most physicians, I think the core idea is that you can practice medicine a lot of different ways. And I still very deeply am connected to the work of individually seeing patients. And I feel like when I was full-time as a practicing physician, my impact was really a one-to-one impact. So like I would see a patient, I would impact them and their family. And then moving into this new world of building companies, I felt like I was able to really create a one-to-many impact. So I am impacting more kids with my ideas and the ways that I've approached that and the ways that we've built systems around that than just seeing individual patients one at a time.
Right. Yeah, no, exactly. I think those of us that are willing to, take risks like join a payer instead of going full-time practice have this drive to do that, to affect the one to many. And I think it is, it's a little bit disconcerting to not do what you just trained for half your life to do all the time. But I think what I tell a lot of my friends who, ask me about my experience and what it's like on the other side. And I think the perspectives that we learn, even starting in med school, and that just become ingrained in a practicing physician's mind of like what life is like in a clinic, is incredibly valuable, because no one on the private equity side or the finance side or the VC side is going to know what it's like to tell a patient that they have, terminal cancer, or that the surgery did not go very well, or that their kid in the emergency room is, not going to make it. We can learn how to do spreadsheets and modeling and PowerPoints, but our perspective on the day-to-day of a clinical experience and an encounter with other humans is incredibly valuable. And I think there's a lot of digital health solutions. There's a lot of companies that try to do something that haven't incorporated the clinical perspective early enough and end up completely missing the mark, where a physician with sort of almost any physician who just went through med school and has taken care of patients could have told them very early on that something wasn't quite right, or this is not going to fly. And I think that perspective is sorely missing in a lot of the stuff that is happening in healthcare innovation, and why physicians who are willing to lend their advice and their experience to, whether it's a startup, a large practice, or a private equity backed platform, we need more physician voices at that table. And so there's tons of opportunity, I think.
You're a physician. You've spent years mastering medicine, but deep down, your impact could be bigger. What if you could take your clinical expertise and use it to shape the future of healthcare without leaving medicine behind? I'm Dr. Allison Kerfman, and I went from being a practicing physician to a startup leader, launching a multi-nine-figure company that's transforming care for 35,000 children. And now I'm ready to show you how. Join the Startup Physicians Launchpad, a 6-week course designed to give you the tools, strategy, and connections to break into healthcare innovation. Whether you want to consult or advise or even launch your own venture, this is your roadmap. Spots are limited, so visit startupphysicians.com and register now. Your expertise is too valuable to stay on the sidelines. Let's change the future of healthcare together. Absolutely. And some of us have to kind of like get over our biases that like payers are evil.
Right.
Private equity is evil. Like
Exactly.
I had people be like, don't you kind of feel like you sold your soul to the devil, like going to work for private equity? I'm like, no, I feel like I created a company that's impacting tens of thousands of chronic kids. And frankly, it works better when you build it in a system where it makes money, because I built it at a nonprofit health system and it got shut down. It ran out of funding.
Right.
So I think that we have to be able to change our perspective and stop thinking in such a siloed way about different aspects of the healthcare system.
Yeah. And I think that's a good transition to how I landed at Rubicon Founders. I think it was probably very similar to your experience. You know, I had learned a lot about specialty value-based care from my seat at Blue Cross, designing payment models, but also learning about new health services solutions on the provider side that were coming to plans to try to sell what they're doing. And a lot of times they were trying to sell into the plan to get reimbursement for another transactional thing, whether it was a diagnostic or, a digital management platform. In my mind, there's tons of really amazing, innovative clinical ideas that just don't work that well in fee for service. It's like moving a mountain to try to get that reimbursed in fee for service. And it doesn't actually capture the value of what it's offering. I continue to get more and more exposure to, venture-backed or private equity-backed health services solutions on the provider enablement side, and got to learn about what worked and what didn't. What were the characteristics of a solution that a payer wanted to buy and roll out in order to become aligned with the healthcare delivery system as opposed to antagonistic. And that's really, in my mind, the goal of value-based care, is to have the payer be a partner in, delivering the right care to patients and reimbursing appropriately for good quality care. And the way to do that is for the provider or the delivery system to take on some sort of, quote, financial risk. And that is through an alternative payment contract. Now, the term risk is obviously loaded, and providers shouldn't be they shouldn't be putting their business their livelihood on the line through a financial contract. That's not the goal. The goal is really to align them and have them be incentivized to deliver better care at a lower cost, more efficient. And to do that, you have to get more upstream and start preventing bad things from happening, start identifying chronic conditions early or exacerbations early, which is not something that specialists spend a lot of time trying to do or thinking about, because it doesn't make any sense to do. It's not what we're trained to do. We typically think that's primary care's job. Once they come to us, I'm going to use the hammer that I was trained with to hit the nail. When I met the Rubicon Founders group.
When was that?
That was in late 2021. And, they were working on sort of a concept of how do we move oncology in this value-based care direction? And because I had done some work with oncology payment models at Blue Cross, partnered with UNC Chapel Hill to help design sort of a payment model, it didn't work, actually. My attempt at Blue Cross North Carolina to put together an oncology value-based payment model was unsuccessful. And so I sort of had learned from that and knew what we needed to do on the physician enablement side to be successful in oncology value-based care. And so I, started out as an informal advisor and then joined the company full time because the perspectives that I was able to bring, I think, were helping the incredibly talented and smart team that was trying to figure out what we were going to do in the oncology space, what we were going to either build or invest in. It helped direct their thinking.
That was absolutely my experience as well. And I think it's worth noting that not all firms are as committed to that as Rubicon Founders and Adam Bowler. And I felt like my voice as a physician was so valued. It was considered critical when we were building the Imagine model. Mm-hmm. And I know you and I were, both at Rubicon at the same time. And I really, truly think this is a firm that cares a lot about getting the model right and knows that you need clinicians to be able to create that. So I think you and I were both incredibly fortunate to mm-hmm. both have met each other in that role, but also to work with a firm where they're bringing this wealth of knowledge around value-based care and contracting and financial modeling and healthcare economics. And we were able to really bring that clinical side of things to different companies that we were building.
Yeah. And I think, back to the point you made about broadening your horizon on, what's out there in healthcare and not immediately saying health plans are bad. I met a lot of amazing people at the health plan that really are trying to do the same thing that we as clinicians are trying to do.
And believe it or not, they can be mission driven as well.
They can be mission driven too.
Right.
Absolutely. They have a different set of tools and a different perspective on how they can actually do that. And that might appear misaligned with, clinical care. But I agree. There are a ton of people who are mission driven at the plan and who really care about the population of North Carolina and have been there for 20 years trying to help improve access and affordability to healthcare. Same thing on the private equity side. There's no other way. And so we're very, very close to launching a physician enablement company in the oncology space where we're only reimbursed and we only do well as a company if patients have better outcomes. And we're putting sort of the entire business model on the line, and we're putting our money where our mouth is to deliver on those outcomes in partnership with medical oncologists. It's taken about 3 years to get to the point where we're ready to launch this company. And to your point, the clinical model has to be
solid,
more than solid at this point, like very evident, like foolproof that this is going to be successful. And that's how we de-risk companies for launch at Rubicon, as you well know. But I think the idea that a private equity firm over here is the same as a private equity firm over here is very, very different, because you really have to look at not the funding behind the entity. It's what is the entity going to do and how is it going to make money? And in our case, it only makes money if patients do better. And so what better way to align financial incentives than to have a value-based enablement company for cancer patients who have tons of needs, who have tons of services that, are not well reimbursed in fee-for-service, that community oncology practices struggle to pay for and actually often do at a loss because the patients need it. And so if we can flip that financial incentive and make the supportive care services that patients need a profit center for the practice through value-based contracting, and really what it hopefully is going to be able to do is reallocate dollars that are are currently going to hospitals for bad outcomes for patients having a complication or admission or a readmission or unnecessary end-of-life care, and reallocating that back into the provider healthcare system, delivery system at the practice level for things that patients actually want and need and that are good for patients. And so, I think the long circle is thinking about how these things work from an academic standpoint, the research, like, what are the problems that we're trying to solve? What are the low value, inappropriate care that happens day to day? That's health services research. We define problems and sort of we identify them. Then going to the plan to try to change the financial construct under which physicians practice, and then coming back around to actually helping physicians be successful in these value-based contracts, and relying on those initial the health services research findings of where is the opportunity to actually make a difference in outcomes and have that be, as you mentioned, financially supported and something that if we can have it make money and have it be tied to good patient outcomes, then we accomplish that win-win, and we get providers more resources, we get patients more things that they need.
Yeah, absolutely. I think you and I have in some ways very similar paths, that we started in a very academic research, metrics focused, problem focused career path, took a crazy veer off the path in a way that really was chasing an opportunity that was an opportunity to make a much bigger impact, and to also gain a lot of skills and perspective and look at things from a different angle. And then of course, crossing paths and meeting each other at Rubicon. And before we started recording, you were saying some very interesting things about, both of us have a ton of physicians come to us say like, your job is so cool. How do I work in startups? And obviously this podcast has been one of my responses to those inbound requests, and helping bring inspiring stories to physicians to hear about other ways people have approached things. But I really loved what you were saying about what is your response to doctors who say like, startups sound cool. How do I work in startups?
I think neither of us had the goal or intention of founding a company or working in the startup world or the private equity world. And I think when I reflect on how I went to the plan and then found myself at Rubicon and founding this company, is really the common thread was there was something that I found really interesting that I wanted to help solve. And that was, if we realign financial incentives to actually reward good quality and delivering efficient healthcare, could we improve sort of the experience of both being a doctor and being a patient under that environment? And so I was really pursuing the idea of learning more about that question, and started with research. It then went to being on the payer side, and then ultimately found myself on sort of the founding startup side, just because I was continuing to follow a question that I found very interesting. And I think what I typically say to people who ask me that question is, startups might be one way that you're able to have the impact that you want and to solve a problem that you really care about. It's a very powerful way if it's done right, but it's not the only way to make an impact from one to many. And I really encourage people to think about what is the problem that they feel fundamentally very passionate about, that they want to solve, and then find others that are like-minded and thinking in the same way, that are doing something about it. And then just have conversations with them and learn about what they're doing, express interest in contributing to that cause, and tell them why it matters to you, what you see day to day in the clinic and how it affects your ability to provide good patient care, what causes you to be burnt out with the fee-for-service environment, and really be crisp on what it is that interests you and what you want to spend, all day working on and all night thinking about. And if it happens to end up that there's someone doing a startup that could use your advice or direction, being an advisor is a great place to start, demonstrating your value and just, inherent perspectives that you don't even know you have, that are like mind-blowing to some of these people doing startups and the finance types, and showing your value that way, and then sort of taking on more and more responsibility.
Yeah, it's such an interesting perspective, because when I think about it, starting a startup was not on my, roadmap or bingo card. I would have never, ever guessed that this is what I would have done. I was following a problem. It was something that was like palpable in my practice, just how hard life was for these kids and their families. And that led me to lead a small program at a nonprofit health system, and just continue to press the issue and ask the question, like, how can we make this better? And my involvement in that helped me to really deeply understand these families that we were serving. And even when, you mentioned a payment model that failed, like a failure in your career, and you probably learned so much from that. And technically, my program failed too. It lost funding and it succeeded clinically, but failed financially. And that was exactly the pathway into building the next thing and the one that did work. I love that perspective. I think that, I recently was speaking to a group of physicians, and I asked them to raise their hand if they could think of a problem in healthcare that affected their patients. And of course, 100% of the people raised their hand, because we all feel it. And I asked if anyone had any idea of how they would approach that problem, or a possible solution to that problem. And of course, again, they all have perspective on that. I told them, you're all thinking of a different problem. Like, you're all coming at this from a very different perspective. I would have never been thinking about benign prostate cancer surgeries. That's a very unique perspective that you had from caring for patients. And you probably wouldn't have been thinking a whole lot about kids with G-tubes, but we're all bringing a different set of knowledge and skills and life experience with that human interaction, understanding what your patients are going through and where their challenges are. And I just think you're right that we have knowledge and skills that can be mind-blowing to a different environment, that these people who are working on building companies may have no idea what the problem is or how to solve it from the very detailed clinical lens. So
I think the cool part also is the reverse. I mean, I've learned so much about how to take an idea that's clinical and put that into a business model and then actually make that reality. So you're right. I think we contribute in a lot of ways for these health services, healthcare delivery companies where, the product is an experience for a patient and oftentimes for a provider as well. But like the infrastructure and the knowledge to go from a clinical idea to a business like Imagine, and hopefully like the one we're launching in oncology, requires a totally different perspective. So it's really fun to partner with those types of people. And then the other thing I'd say about, startup world is it's not as glamorous as it sounds, as you know. I think, there's a lot of...
It can be a little gritty sometimes.
Be a little gritty. I've done more Excel and PowerPoint than I ever thought I would do, but it's what it requires at this point of the company's life cycle. And so, there's parts of every job that we don't love and that are rote, and the same thing with startups. But I think having the mission at the center of everything that we're doing, both with patient care and then also with the sort of non-clinical path that people want to take, making sure that that's aligned with what you really care about, what you're passionate about trying to solve. You're going to end up in a good spot. It might take a while, but that would be my advice.
Yeah, absolutely. And I definitely gained a ton of skills spending the time that I spent at incubating Imagine at Rubicon. And I don't know if you had this experience. At one point, they were like, Allison doesn't know how to pitch. We're going to do something called, let's do a murder board. I was like, what the heck is a murder? They're like, we're going to put you in front of everyone. You're going to talk about Imagine. And then we're all going to attack you.
Oh, wow.
That sounds like a lot of fun, but definitely improved my pitching skills. So
that's
definitely taking on new skills that you don't have when you enter a new environment. But I'm sure you've learned just as much as I have, if not more, from being around people with different backgrounds. So
absolutely. I always say my clinical days are that's the day I know what I'm doing. And then the other days I'm sort of learning.
Flying by the seat of your pants?
Flying by the seat of my pants, which is the way I like it. But it does take some adjustment for sure.
That is interesting because I feel super chill and comfortable when I'm in the ER now, because I'm like, oh, this is my very straightforward day.
Yeah, exactly. Yeah.
Well, awesome. Well, I can include your LinkedIn in the show notes if anyone wants to reach out to you. I am so grateful for your perspective and your friendship and just the way that we've been able to help each other with our careers. And thank you so much for coming on today.
No, absolutely. And thank you. And really inspired by what you did with Imagine and what they continue to do. It's something that we're very, very proud about at Rubicon, and I'm cheering on and helping as much as I possibly can with it. It's a much needed thing in our healthcare world. So thank you for your part.
Thank you so much. And congrats on the company that you're launching. And thank you everyone for listening today. Again, if you want to reach out to David, I'll put his LinkedIn in the show notes. And I hope this was inspiring to all of you as it was to me, that we all have skills, we all have ideas, we all have problems we want to solve. And sometimes all it takes is following that problem, and it can lead to interesting opportunities if you're willing to take them. So thanks everyone, and I'll see you soon.
Thank you for listening to Startup Physicians. Don't forget to follow, and share.